Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 146 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, GMB, a 37-year-old male patient is admitted to your medical intensive care unit with a chief complaint of respiratory distress. He has a past medical history significant for a 3-week history of cough and pleuritic chest pain that has worsened with time. His chest X-ray shows bilateral infiltrates with ground glass opacities. GMB is HIV seropositive but not currently receiving antiretroviral therapy because of non-adherence. He requires intubation and is receiving 40% fraction of inspired oxygen, abbreviated as FiO2. Some of his pertinent lab results include, a serum creatinine of 1.0 mg per deciliter, CD4+ of 100, his LDH is equal to 550 international units per liter, a PaO2 of 88 mm of mercury, a PaCO2 of 40 mm of mercury, and a WBC 4×10³ cells per millimeter cubed. He is allergic to sulfur drugs, and has a G6PD deficiency. So my question to you is, apart from adjunctive corticosteroids, which of the regimens for presumed pneumocystis jirovecii pneumonia, abbreviated as PJP, listed below would be the most appropriate for GMB's treatment? Would it be A. Atovaquone 750 mg taken orally twice daily, or B. Primaquine 30 mg taken orally once daily, plus clindamycin 600 mg IV thrice daily alone, or C. Pentamidine 4 mg per kilogram IV once daily alone, or would it be D. Co-trimoxazole 15 to 20 mg per kilogram IV, divided every 6 hours? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Pentamidine 4 mg per kilogram IV once daily alone. The patient's history and clinical presentation suggest PJP. It is severe enough to warrant intubation, and the patient has a significant alveolar arterial oxygen gradient. The usual drug of choice for such patients is cotrimoxazole, but because this patient has a sulfur allergy, this is not an option that makes answer D incorrect. According to the HIV-OI guideline, the second-line agent for the treatment of severe PJP is intravenous pentamidine. Because the patient had severe hypoxemia, adjunctive steroids should be administered. That makes answer C correct. Atovaquone and primaquine or clindamycin regimens are usually reserved for patients with milder PJP. Furthermore, primaquine should not be administered to someone with a glucose 6-phosphate dehydrogenase deficiency. That makes answers A and B incorrect. Let's move to the next question, please. And the next question reads, RTL, a 50-year-old female patient with acute myeloid leukemia is admitted to your hospital for induction therapy. During the patient's clinical course, she develops respiratory distress, for which she is admitted to your medical intensive care unit. She has neutropenic fever and is empirically treated with meropenem plus gentamicin plus vancomycin. On day 5 of empiric therapy, blood cultures are growing pan-sensitive Escherichia coli. Some of her pertinent laboratory values and vital signs include a blood pressure of 115 systolic, 70 diastolic, a heart rate of 84, a body temperature of 38.4 degrees Celsius, an absolute neutrophil count of greater than 50 cells per millimeter cubed. So my question to you is, which of the regimens listed below would be the most appropriate antimicrobial regimen for RTL's treatment? Would it be A. Add voriconazole, and continue all other antimicrobials for 14 days, or B. Discontinue vancomycin, and continue meropenem and gentamicin until neutrophil recovery, or C. Discontinue all empiric antimicrobials, and initiate ampicillin intravenously to treat until neutrophils recover, or would it be D. Continue meropenem, gentamicin, and vancomycin for 14 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Discontinue all empiric antimicrobials, and initiate ampicillin intravenously to treat until neutrophils recover. This patient has febrile neutropenia with no recovery of neutrophils. According to the IDSA febrile neutropenia guidelines, when a source of infection is identified, the empiric antimicrobial therapy can be de-escalated to a more narrow-spectrum regimen according to the antibiotic susceptibility report. In this case, because the Escherichia coli was pan-sensitive, it would be appropriate to de-escalate to a narrow-spectrum antimicrobial. The guidelines also specify that antimicrobial therapies should be continued for at least 14 days and until neutrophils are greater than 500 cells per millimeter cubed. That makes answer C correct. Although the patient continues to be febrile, an otherwise stable patient with continued fevers rarely requires additional antimicrobial therapy according to the guidelines. Hence, continuing more broad-spectrum therapy than necessary or adding other antimicrobials is unwarranted. Therefore, answers D, B, and A are incorrect. Let's move to the next question please. And the next question reads, DSS, a 58-year-old male patient undergoes laparotomy for duodenal perforation and peritonitis, after which he is admitted to your surgical intensive care unit. Post-operatively he has a urinary catheter in situ. On day 4 post-op, he is extubated and his urinary catheter is removed. On day 6 post-op, DSS develops signs and symptoms of a urinary tract infection with fever, urgency, and frequency. Urinalysis is done and the lab reports no nitrates, and no leukocyte esterase. His urine cultures grow 100,000 colony-forming units per milliliter of Escherichia coli. You are asked to discuss this case and determine whether DSS will qualify for the definition of catheter-associated urinary tract infection, abbreviated as CAUTI, according to the CMS criteria. So my question to you is, which of the statements listed below regarding the diagnosis of CAUTI in DSS's case is most appropriate? Is it A. doesn't qualify for the definition of CAUTI because his catheter was removed 2 days before symptoms ensued, or B. qualifies for the definition of CAUTI because he is asymptomatic and had recent urinary catheter, or C. doesn't qualify for the definition of CAUTI because the patient has a negative urinalysis, or is it D. qualifies for the definition of CAUTI because he is symptomatic and has positive cultures? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Doesn't qualify for the definition of CAUTI because his catheter was removed 2 days before symptoms ensued. The CDC definitions for CAUTIs, which are used by the CMS reporting system, were recently updated. Because this patient had his urinary catheter removed for more than 24 hours before developing UTI symptoms, this case doesn't satisfy the definition of CAUTI, therefore answer A is correct, answers D and B are incorrect. The current CDC CAUTI definitions don't consider the results of a urinalysis, therefore answer C is incorrect. Let's move to the next question please. And the next question reads, WKKA is a 47-year-old female patient is brought to your accident and emergency department by her husband. She has a chief complaint of mental status changes, lethargy, and she has a body temperature of 39.4 degrees Celsius. He informs the clinician that she had a very severe headache 1 day ago. She has no significant past medical history. Her diagnostic workup results are highly suggestive of meningitis. A lumbar puncture is done and a high initial pressure is noted. So my question to you is, which of the interventions listed below would be best initially for WKK? Would it be A. Initiate empiric ampicillin, cefepime, and vancomycin, or B. Initiate empiric ceftriaxone and vancomycin, or C. Await laboratory and microbiologic analysis, or would it be D. Administer dexamethasone 0.15 mg per kilogram intravenously? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Administer dexamethasone 0.15 mg per kilogram intravenously. This patient presents with community-acquired meningitis. The high opening pressure is suggestive of a bacterial etiology, of which the most prevalent pathogen for this patient's risk factors and age is Streptococcus pneumoniae. Administering dexamethasone before initiating antibiotic therapy decreases mortality in patients with Streptococcus pneumoniae meningitis. Therefore answer D is correct. Awaiting laboratory and microbiologic test results analysis may cause inappropriate delays in therapy, therefore answer C is incorrect. In addition, although administering antimicrobials is a good idea, the beneficial effects associated with dexamethasone are diminished if administered after antimicrobials have been initiated. At the very least, corticosteroids should be administered concomitantly with antimicrobials, therefore answer B and A are incorrect. Let's move to the next question please. And the next question reads, JCK, a 57-year-old male patient is admitted to your medical intensive care unit with a chief complaint of acute necrotizing pancreatitis. He has an infected pancreatic abscess, which is being treated with meropenem and vancomycin. 2 weeks into the course, the patient develops a fever and leukocytosis. He also becomes hemodynamically unstable and oliguric. He is initiated on caspofungin empirically to cover for possible invasive candidiasis. His blood cultures turn positive with a preliminary result of yeast. Your institution is equipped with PNA FISH technology, which identifies Candida parasilosis on day 2 of therapy. JCK remains hemodynamically unstable. So my question to you is, which of the strategies listed below would be the most appropriate for JCK's antifungal therapy now? Would it be A. Switch to fluconazole 400 mg IV once daily, or B. Switch to liposomal amphotericin 5 mg per kilogram per day, or C. Switch to voriconazole 6 mg per kilogram twice daily, or would it be D. Continue caspofungin while fungal susceptibilities are finalized? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Switch to fluconazole 400 mg IV once daily. The PNA FISH technology is designed to identify pathogens earlier. It performs well, with good sensitivity and specificity, hence the identification of Candida parapsilosis shouldn't require verification from culture, therefore answer D is incorrect. The drug of choice for the treatment of Candida parapsilosis is fluconazole, therefore answer A is correct. Although echinocandin, voriconazole, and amphotericin would all cover Candida parapsilosis, they all have a broader spectrum than is necessary, making them not the ideal choice, therefore, answers B, C and D are incorrect. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 147.